Okay, so good afternoon everybody. This is Simon Bartold and this webcast is brought to you by LBG Medical, and we're going to talk about something very topical this afternoon. It's the supposed connection between pronation and injury. So the topic is excessive pronation and injury. Where are we at right now? Now you're probably going to think I'm a bit crazy as we go through this because I'm going to be telling a story, but stick with me because basically we are going to get to a point at the end that hopefully will make sense. But I guess we can all say that in the past 10 years there's been huge change in terms of footwear. Our concept of orthotic devices, orthotic therapy has all changed quite radically. But the question I need to ask is, well, has it really been driven by quality science? We have had big changes in biomechanics theories. We've had quite a change in the specificity of individual sports to footwear design and maybe even orthotic design. We've seen new trends and paradigms. Some have stuck, some haven't. And we've seen big changes, particularly in the footwear industry, in the way things have been marketed. And I can give you an example in terms of minimalism, where that trend really drove massive changes to the way the industry worked and the way people thought about running footwear. If we have a look at the traditional model of how we might like to think that athletic footwear is designed and also, I guess, athletic therapy, we can see that right down the bottom is marketing, and then following that with innovative manufacturing. The next segment is material research, and then right at the top of that we see, of course, what we want to see, and that is biomechanics. Well, if you believe that model, you believe anything, because the model probably looks more like this, that right at the top is marketing, and marketing drives everything. Below that we've got lifestyle trends. Lifestyle trends are really very important market driver. Below that we have socioeconomic forces, in other words, how much can people afford. And right down at the base, things like innovative manufacturing, which is a very important part of what drives footwear, and then material sciences. Now you'll notice there's something missing, and that is this nasty little excrescence on the side here, which is called biomechanics. So maybe not as much influence as we would like and hope. It's certainly a fair way down the pecking order. If we have a look at this question, has science been hijacked by hype? Well, I think maybe the answer is, to a large degree, yes, it has. Let's ask a specific question then. Can athletic footwear be designed to enhance foot and leg movement, and can it do so in such a manner that performance can be improved and injury reduced? That's a huge question, as you can see, and one that we'll strive to get an answer to. Specifically, can it make an athlete run faster? Can it make an athlete jump higher? Can it spin a soccer ball? And can it kick a football further? Well, I can answer that pretty easily. The answer to these questions are yes, 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 and yes. But there are some caveats to it. If we look at the conventional wisdom, what we know, or what we think we know, well, we think that excessive subtalar joint pronation is implicated in injury in runners, and therefore that shoes should address contact phase pronation. And this is what so many people have talked about for so long. There's still a lot of people out there who are analysing gait, specifically trying to identify contact phase pronation. We think that cushioning is important, and we think therefore that softer shoes will attenuate shock better. Furthermore, I guess we put forward the argument that relatively inflexible shoes will provide the best support for a foot, especially if that foot does overpronate, whatever that term overpronation means, and that only new technologies apply to modern footwear. Well, obviously the statements in these last two slides are probably completely argumentative and probably completely inaccurate, and we need to explore it a little bit more. We do believe that science can solve all problems, but sometimes that's not the case either. In terms of looking at overpronation, this is such a thorny issue. I can maybe refer you to Ian Griffith's website, where he wrote an excellent article on overpronation and what exactly it means. And many of us have been concerned about this term for quite a long time. It's been implicated in many lower limb injuries, but the mechanism of this contribution has still not been established. And we can talk about things like bunions, big toe joint pain, shin splints, a horrible term, plantar fasciitis, an equally horrible term, anterior knee pain, low back pain, and I'm sure if we searched far enough and wide enough, we'd probably find that it was implicated in hemorrhoids. You never know. But right down the bottom here in tiny writing that you can't read, I've said the causal evidence to directly link excessive pronation and pathology has never been established. There has never been a direct link between overpronation and pathology. So we have to take that on the chin. Now, many of you are using the tissue stress model, which is one I favour. It's not without its quirks, but it's definitely a better model, I think, than assuming that pronation is the root of all evil, because it simply isn't. If we look at design issues in footwear especially, and we look at the concept of motion control versus motion enhancement, this is still also quite relevant to orthotic therapy. We look at proprioception versus sensory motor issues, and we look at matching the right shoe to the specific sports. All of these things are actually quite difficult to do, and quite a task from a design perspective. Control versus enhancement is really quite interesting because in the past, motion control strategies have been a fundamental requirement for foot and leg stability and gait. And you can think about design parameters like stiff heel counters, flares, what we call link componentry, which is the bits and pieces that link the rear foot to the forefoot. All of those things have been considered very important for motion control. But the question is, what is motion control, and do we believe in motion control? I think the parameters that have evolved, have had the overriding desire to block motion. And I'd put it to you that blocking motion is not such a great thing in the foot. And especially they've been designed to block motion during the first 25% of the stance phase of gait. Now, the great conundrum here, of course, is that we actually want the foot to move properly. We want it to pronate during the first 25% of the stance phase of gait because it actively attenuates shock at this time. It's one of the most important shock attenuating mechanisms along with knee flexion. So why would you want to block that off? The answer is you wouldn't. So we do have this big question mark there. If you have a look at the distribution of body weight, it's pretty easy. If you're just standing in the anatomical position like this and I draw a line that splits the body in two, well, then that's where the centre of mass is going to pass over the exact centre. But there aren't too many sports where you stand completely still in the anatomical position. It just doesn't happen. If it did happen, the body weight would have a mechanical advantage over the foot and it would pronate. But we work in different models these days. This is a very static model, and I want to put it to you that if we were just dealing with a static model where you were just standing still or jumping up and down the spot, well then perhaps the features of the past, very stiff midsoles, high torsional rigidity, would be very important. But of course we work in a very dynamic system. Motion's very complex. It's a highly coordinated event, and it requires a very intricate interaction between all the systems that allow us to run, including the brain, which of course controls all movement. So it's very important that we don't have too much shock go through to the brain because it affects it. But the brain controls all movement via nerves to the muscles, tendons and ligaments, and also thereby allowing movement through the joints and bones. So this is a concept of dynamic stability, and dynamic stability involves incorporating all the systems into a shoe that are going to address all the forces applied to the foot, right through from heel contact to mid-stance and then on into propulsion. So if we accept that that's probably where we're at right now, what would you be needing in a shoe or indeed an orthotic device? What are the design parameters? Well, you'd need a combination of both. You need a combination of static stability and dynamic stability. Static stability because it means that perhaps you can slow down the contact phase velocity if that's what you want to do and if that's necessary. And I might add that's a very big if. You might also want to be thinking about not controlling motion but controlling deformation, and that's deformation of tissues at lots of different levels. So you can think about tibial stress fracture and how the bending moment of the tibia is involved in this. You might be wanting to try to stop the deformation of that bending moment. Now, I don't believe it's possible to build a shoe that controls foot motion. So I think that we really try to focus on the net negative effect of footwear, and it's fair to say there is a net negative effect, but some shoes obviously are much better than others in regards to that. So in terms of cushioning now, we've covered stability. What do we think we know about cushioning? Well, we think that cushioning is pretty important. and we think that we want a combination of both stability and cushioning. We think that soft and midsoles increase cushioning, and that conversely highly stable shoes have poor shock attenuation, and therefore that stability and cushioning are simultaneously required in a quality running shoe. Well, if we put that under the microscope and have a look at what the science tells us, is cushioning really important? I've got a couple of studies here. This is from Martin Shorten and Winslow from 1992. Shock to the head has to be maintained below a set threshold because you've got to maintain stability of your head at impact, because if you don't, then you're going to shake up the vestibular and balance systems, and that is going to make you fall over. So we definitely need to make sure that we cushion that initial impact shock effectively. This is quite interesting. The human body controls the transmission of shock to the skull through active and passive attenuation. Active attenuation, as I've mentioned, things like knee flexion and pronation, and passive attenuation through the viscoelastic properties of tissue. So we're thinking about the wobbling mass of muscle and fat, even the visceral units, the organs, they all actually vibrate, and they do help to passively attenuate shock. So what is the role of the shoe? Well, shoes with harder midsoles reduce the initial impact force. This has been shown by Bob Marshall and co-workers back in 1999. Now, that's not a misprint. Shoes with harder midsoles reduce the initial impact force. So that's completely contrary to what we might expect. And the reason for this is that they may well allow for a greater range of contact phase pronation, which we see as being a positive thing. And this is probably a response to try to reduce the potentially harmful load that occurs at heel strike. As sole hardness is increased, ground reaction forces don't significantly increase. And again, you can see these are very old references dating right back to 1987. So we've known for quite some time that there is a bit of a conundrum here. So what's this motion control versus motion enhancement paradigm that I'm talking about? Well, I think we do need a complete rethink of the conventional wisdom that we apply to running shoe design and probably also to athletic therapy. And I guess that the top secret for 2000 would be this athlete running barefoot. Now, at this point in time, you probably think I've gone completely crazy because many of you know I've been a vocal advocate against the barefoot and minimalist movement. But the reason I wanted to run through these slides was that this was a presentation that I gave to the University of South Australia Postgraduate Masters of Sports Physiotherapy course in July of 1999. So for 26 years, I've now been saying that I think that there were things that we needed to address in terms of the way we designed orthotic therapy and also athletic footwear. Now I want to bring us up to date now, and we're going to talk about where we are right now in 2015. And this is a really nice paper from DX and co-workers, and they were concluding that abnormal levels of pronation, whether restricted or excessive, can alter gait patterns in ways that can potentially increase the risk of running-related injuries. So what we see, altered gait patterns, increasing the risk of running-related injuries. This is a very important concept. But the biggest problem we've had historically is that we have tried to define a criterion of normalcy for running athletes. Now, if you have to think about that, that's a really very, very difficult thing to do because the human organism is so incredibly variable. And to try to talk about a criteria for normalcy is really not at all appropriate. I don't think you can apply the term normal to the human organism because of this great variation. We've worked on a model that you're all very familiar with. This is the root model that looked at bisections and divisions and statements about where the foot and leg should be in relation to the ground and also the forefoot. But the issue with this is that this was a theory. It's called root theory for a reason, and that is that it is a theory. Now, I'm not in any way denigrating the work of Root, Weed and O'Ryan from 1977. It was landmark work, and it's been enormously useful. But the problem I do have is that the concept of subtalar neutral somewhere, somehow became cast as fact, and it's not. It's a theory, and there probably is a better way. Across so many studies now, all of the data collected from pain-free and injury-free subjects and athletes shows that very few individuals actually meet the historical definition of normal. And so we really should be taking that term normal out of our understanding of the way the human body works. All the research points to the following. It's very difficult to accurately and repeatedly measure foot-level pronation. The relationship between pronation and injury is extremely poorly understood. We still don't understand it very well. And the historical concept of normal is quite erroneous, and so I'd encourage you to stop thinking about it that way. Variation between people at foot level, in foot level movement patterns is extremely high, and this is completely normal. So we really can't put any sort of definition of what is normal and what is abnormal in terms of foot level movement patterns. So should we then abandon the term over pronation? Well, perhaps we should. I think we just don't understand enough about it to be able to talk about it in a meaningful way. What we should maybe be doing is this: accurately identify the injured anatomical structure, in other words, formulate a diagnosis, identify the structural and functional characteristics of the foot and the lower extremity, determine the most likely types of tissue stress causing the pathology, and design the management plan to reduce these stresses. So you know this and you recognise this is the tissue stress model. It's still the best model we have by a long way. I like it because I work with athletes and it recognises dynamic function far more than root theory does. Root theory is a very static way of assessing an athlete, and I'm very much into looking at the dynamic features of a sport that cause an athlete injury under loading. So it's very, very important you try to recognise these dynamic stresses. The last thing you do is optimise gait function accordingly. So we're moving in now to the realm of things like gait modification, gait retraining. Some very promising research telling us that we can actually make small tweaks, small changes to the way somebody moves or somebody runs, and this can have a big influence on their injury recovery. So what about this little conundrum of overpronation and foot orthoses at the level of the knee? So many of us use orthoses to treat patellofemoral pain syndrome. There are two good RCTs now that support their use, one from Natalie Collins and co-workers. She's a researcher who spent a lot of time looking at this, and she is very adept at her research, and the other from Eng and co-workers. So two have supported their use. There's absolutely no doubt they work, but the model for efficacy of foot orthoses is baseless. So the model that maybe was described first by Dave Tiberio a long, long time ago that looked at foot pronation causing internal tibial rotation and a displacement of the patella in the trochlear groove really can't be supported. So the question is, we've got this paradox. The majority of cross-sectional studies and all the prospective studies show that there's no link between excessive pronation of the foot and patellofemoral pain, none whatsoever, and yet they do work. So what is going on here? What do they actually do, and why do they work in patellofemoral pain syndrome? Why do people with patellofemoral pain syndrome get better with proximal control exercises? So we know for a fact that they get better with orthotic therapy used judiciously in the right way, and we also know that they get better if we do proximal strengthening exercises for things like the hip flexors, in particular gluteus medius, and also perhaps some core work. So here's the thought experiment number one. It's all about kinetics, not kinematics. If we assume the patella is now tracking, and we assume proximal control is an important part of the treatment for this, and that it will improve alignment and control of the lower limb, assume the foot in this case is rigid and does not move, will proximal control improve alignment? So remember this, that the foot's very rigid, it can't move. Is proximal control going to improve the alignment? The second experiment is, well, the foot isn't rigid, it moves easily, and the force needed to supinate the foot's relatively low. It's relatively easy to change control from the more proximal structures, moves the foot and changes the alignment of the lower limb and helps to resolve the patellofemoral pain syndrome. Well, this is quite interesting. So there may well be a continuum here where we've got a rigid foot at one end of the continuum and a mobile foot at the other end of the continuum. And it may well be that when you have a mobile foot that moves easily, low supination resistance test, that proximal control is going to improve alignment and function quite easily. And at the other end of the spectrum, with a rigid foot, very high supination resistance test, that orthoses are needed in this case, because you've got to change the inversion moment at that level if you're going to have any positive effect on the knee. So you need to learn how to do the supination resistance test, because it may well provide some of the answers that you're looking for. But this is an interesting area of investigation at the moment. At the end of the day, I think what we do know about orthotic devices is that they don't change the kinematics. So the old concept of using an orthotic to change the angle of the dangle is erroneous and no longer appropriate, but rather they change the kinematics, and they change the kinematics quite dramatically. So again, I'd encourage you to think in those terms. That last little model there was from Rodriguez and co-workers. It's a really useful paper. Seek it out. Evaluating runners with and without anterior knee pain using the time to contact the ankle joint complex's range of motion boundary. So it's quite an interesting paper, and I'd recommend you have a look at that. Quite recent, 2013, in Gait and Posture. All right. So that's really all we need to run through for today. I hope that's given you some food for thought. Certainly it is an area of great interest, and we really do want to be having a bit of a think outside the boundaries here about how we deal with the thorny issue of pronation. I hope you've enjoyed this presentation, and I will speak to you again soon.